Hi. Hi, I'm Catherine Johnson. I'm the Medical Oncology Nurse Consultant at Calvary Mater, Newcastle, and today I'm going to let you know about implementing patient-reported measures at point of care in a tertiary cancer clinic. And this is a piece of work that we've been doing at the Mater for over 12 months now. I'd like to acknowledge that we're meeting on the lands of the traditional custodians and owners of the lands of the Awabakal Nation on which our service operates, and acknowledge that these custodians have walked upon and cared for these lands for thousands of years. We acknowledge the continued deep spiritual attachment and relationship of Aboriginal and Torres Strait Islander peoples to this country and commit ourselves to the ongoing journey of reconciliation. So what are patient-reported measures? Patient-reported measures are means of collecting information directly from the patients about their psychosocial, physical concerns that may be experienced either during treatment or during the period before and after. Why do we undertake patient-reported measures? We undertake them so that patients can tell us directly, so that we can reduce hospitalisations and improve survival, and complement the clinical assessments that are done in the clinic and the treatment areas by medical and nursing staff to improve symptom recognition and symptom management, and also to improve health equity by increasing the visibility of patient needs and all patient needs. We know that some patient groups experience less access to health care, and equity is not something that everyone experiences when they receive healthcare. So this is part of our work to close the gap with all patients with regards to equitable access to healthcare and visibility of their needs. So we started over 12 months ago, so about 18 months ago, 15 months ago, and so we have implemented the Cancer Institute of New South Wales Patient-Reported Measures program. This program integrates directly into our electronic medical record, currently ARIA, and this is an improvement on our older models of screening where we used paper. We have adopted an at point of care survey rather than outside of point of care, where patients receive a text message or email to complete the questionnaire. We did this by engaging the whole team. So we are one team here at the Mater. We engaged all of the stakeholders, our administration team, our nursing team, allied health and medical teams, to look at our model of care and develop a new model and new workflows that benefit our patients. We identified key champions, and we capitalised on existing models of screening. So our care coordinators have been screening patients with patient-reported measures for a very long time, many, many years, on paper. And of course, this is great, but it's not possible to screen large numbers of patients when you're using pen and paper. So this electronic integrated mechanism to collect PROMs is a big improvement. We applied staged implementation. Stage 1, we screened patients attending the clinics of 3 consultants, plus all patients attending education appointments in the treatment centre for the medical oncology service. And we did that for 3 months and worked out the things that needed to be modified and adjusted, and then we rolled it out to all patients. So this report is as of June 2024, we started screening. As I said, we have adopted an at point of care model. We use the standard distress screening and Edmonton symptom assessment tool, and it's available in language through the Cancer Institute. Patients complete it on an iPad in the medical centre or on a standalone PC in the day treatment centre. We're about to roll out to haematology when we receive some more iPads from the Cancer Institute, and radiation oncology we hope to commence in 2026. We don't currently screen any patients receiving non-cancer treatment, which is why haematology has been a bit slower to come on. We do initial screening at education or new patient appointments, and then patients are offered the opportunity to repeat screen at every clinic appointment. The results are reviewed by the clinic staff in the medical centres to determine if any immediate action needs to be taken to support the patients while they're here in the service. The cancer nurse coordinators, nurse consultants review the information during their interactions with the patients, and the medical oncologists, importantly, who are seeing the patients in the clinic, can look at the results and determine if any action is necessary. And we have, as part of the implementation, really worked on defining and refining our referral pathways to allied health supports. We did not want this to become a tick and flick exercise when someone identified that there was an issue that they needed support with. We're trying to have a stepped approach to our care, and I'll speak about that on a later slide. Our alerts, our thresholds are 5, but strictly speaking, they have not been set in the system because patients are here. All surveys are reviewed. We have completed 1,806 surveys as of June 2025, and now by August we've completed almost 2,000. So a great implementation, really. You can see on this slide the number of surveys that were submitted. For patients who have declined surveys, it is patients who said yes to the admin staff they would complete it and then hit the decline button on the iPad. It doesn't include patients who declined at the point of invitation. And you can see the unsubmitted surveys, and that relates to sometimes the efficiency of our medical oncology staff who call patients in before they complete, or where the technology fails and they're just not submitted because it times out. You can see on this slide some patient demographics. It's good to see that we have got patients from across all of the age groups in a distribution that we would expect. We know that cancer is a disease of the ageing, and so more of our older patients are completing the PROMs, which is fantastic. We have got a good gender split, slightly more female than male, and for patients who identify as Aboriginal or Torres Strait Islander, you can see the split here. It accounts for about our Aboriginal and Torres Strait Islander patients account for about 6% of the patients who are completing the PROMs in our service. This slide talks about the self-care links. So as part of this program, if a patient identifies that they have any concerns, be it physical, psychosocial, practical, spiritual, or otherwise, they can elect to receive self-care information via email. And you can see here that probably 40% of patients are electing to receive information on their first survey. A small number of patients do not have an email, and another group of patients did not make any indication of whether or not they would like to receive or otherwise. Less than half are opting for no self-care, so that's a good indication that people are interested in receiving some support. You can see here patients who receive self-care links that did or did not breach the statewide threshold, so 5. For the people who didn't breach, it was about 70, for all patients, it was about 73% who received the self-care links. And for the people who breached the threshold, so 5 for distress or 5 for pain, who requested self-care links, you can see that 42% who breached requested support. So not everybody who reports an issue or a concern wants help with that. And I think that is completely valid, and patients have a choice to engage in services in the way that they choose. This slide talks about the distribution of distress for the surveys. So all surveys in the dark, first survey in the medium blue, and the subsequent and second survey in the pale blue. And you can see that patients are generally not breaching, so not going past 5. There's certainly a minority of patients in that cohort. And the second chart here on the right looks at the distribution of distress among Aboriginal and Torres Strait Islander people, who do show some slightly higher levels of distress on both the first and second survey, but it's a smaller cohort. The top 10 problem list, I guess, is interesting for us to think about how we might address some of the issues as a service, at a service level, and not just on the individual patient level. And so you can see here there's not a lot of difference between the general population on the first survey and the Indigenous population. I will point out that sadness is slightly higher rated with our Indigenous patients, and sleep and fears also rate slightly more highly in the Aboriginal cohort. And I guess we're seeing loss of interest in usual activities, tingling in hands and feet, and memory concentration. So slightly different physical problems there as well that are important just for us to be aware of and cognizant when we're dealing with the person in front of us. And so it's important that we not only collect the PROMs, but that we talk to the patients about the results and actually do something with them and support them to receive care that they need. The Edmonton Symptom Assessment Scale on this slide, this is a view of all of the results over 12 months. So you can see that the problem checklist here, so pain, tiredness, nausea, depression, anxiety, well-being, appetite, drowsiness and shortness of breath, similar amongst the general population and the Indigenous cohort. And so I guess it's, reassuring, I guess, that there's no significant differences in patient experience between the two cohorts. So for us, supporting our patients is a priority, and so for patients to be connected with the appropriate level of care and support to improve their experience of care and their wellbeing. So self-care links are the first port of call for us through the Cancer Institute system. Our next step that we can use to provide support is through the EviQ information and the EviQ platform, and the Cancer Council booth that is available on site at Calvary Mater is a great resource for our patients, and we can always attend or encourage the patients to attend to get some more detailed information if they prefer. We refined our referral processes and our referral pathways and the referral criteria as part of this, so that our allied health support staff were not overwhelmed with referrals, and so those referrals are available in ARIA, and all of the referral templates include the referral information, and so I encourage you to have a look at that. Not all patients are eligible or suitable for dedicated support, and you can see that we have an extensive MDT that we can draw on to support our patients as well if information alone is not sufficient, and we work extensively with our non-government organisations to help support our patients in more practical ways. And you can see some of those listed on this slide. So some of the reflections for us, the challenges and the achievements over the last 12 months since we have been implementing. We've taken a whole of team approach, which was a real strength. We included all of the team, admin, nursing, allied health and medical teams to create and adjust workflows that benefit our patients. We capitalised on the existing models of screening, and I think because we had a history of screening patients, it was easier for us to transition, and that has been a really good thing for us. It's meant that we have adapted quite quickly. Change is hard. Cultural change is especially hard. It's change management and cultural shift. It's still a work in progress. Our staff don't stay the same. Our patients don't stay the same. We are constantly re-educating and educating staff and importantly, educating our patients, and they receive resources in their new patient letter advising them that they will be screened and that they will be invited to do that at visits, and a link to some information should they choose to access that. Consistent stakeholder engagement was a real strength. Having champions led credibility to the program, and the Cancer Institute New South Wales team have been invaluable in providing support to us because we were the last LHD to come online, and so we could leverage off the lessons learned from across the state. So that's been a real win for us. Nonetheless, change is hard, and it's a constant process, and really greatly value all of the team who've been involved in adjusting their workflows and changing the way that they work with patients and the rest of the team. Ultimately, this is leading to better value care, so patients are empowered to better self-care, leading to better use of resources across the hospital, especially through the streamlined referral processes. And we've seen that particularly for the dietetics team, who report that they have a much better process now. So I encourage you to have a look at those referrals on ARIA and look at the templates, and you can make the referral as well. Some of the technical issues that we encountered, we don't run on the New South Wales Health Wi-Fi, so we needed a booster and some extra support for making the iPads work to their peak performance here. And training and education is an ongoing work in process. As I said, staff don't say the same. They come and go and change. And so if you have any questions, please reach out to any of the team, particularly me, if you would like some more information or deeper understanding of the patient-reported measures at Calvary Mater. And I'll stop there. Thanks for listening. I hope you enjoyed the presentation.